This is the Dental Up Podcast, your daily source for insights from dentists and leaders in the industry. Brought to you by Keating Dental Lab, a full-service, award-winning dental lab that is here to add value to your dental practice. With high-quality restorations, friendly, reliable service, the best products and prices, come experience the Keating difference. Visit KeatingDentalLab.com for details.
Good afternoon and welcome back to the Dental Up Podcast. I'm Bob Brandon, your host and the general manager here at Keating Dental Lab. Today's guest is phenomenal, and this is a dentist that I have a tremendous amount of respect for. Everybody here listening is going to learn the most important thing about the clinical practice of dentistry from my good friend, Dr. Alan Weinstein. Dr. Weinstein, good afternoon.
Good afternoon to you and all.
How's your day been so far?
Day's good. Every day's good. Some are better than others, but every day's good.
I agree. Well, thank you so much for spending time with us. You are, truthfully, Dr. Weinstein, you're one of my heroes. I can't believe that you have a career that spans 56 years in this field.
That's correct.
And when we talked the other day, I put you right up there. You've actually surpassed my father. My father worked in the trenches for 50 years, and you have surpassed him, and you're still going strong. I still see your cases here in the lab every week. So why don't we go back to the beginning and tell us where you went to dental school, when you graduated, and what your first job out of school was like.
Okay. I went to undergraduate, University of Georgia in Athens. Did my dental training at Emory University here in Atlanta when we had a dental school at Emory. It was closed in 83, I think it was. Spent about 11 or 12 years as a fixed professor at Emory and the fixed crown and bridge department, and also doing private practice along with that at the same time. So I started out in 67. Went into practice with my father-in-law and my brother-in-law and have been practicing for the last 56 years. I still practice 4 days a week. I'm in my office every morning around 6:15, and I leave 5 o'clock to 6 o'clock, depending on how much lab work I have left to do. And that's how my days consist of. I still enjoy practicing as much as I ever did, and it's not a job. It's not even a profession to the degree it's fun.
It's fun. I love that because if you truly enjoy what you do, it's not really work. It's a passion. That's beautiful. You mentioned a key point there, lab work, because you are one of only a handful of our customers, and we now have up to 1,000 dentists on a monthly basis that does their own lab work. And tell me why you still do that.
I pour all my own models. I then, of course, send them to Keating, where y'all mount them and send them back to me for dye trims. I trim all my own dyes. Some people might say I'm old-fashioned. I personally still believe that when you go to scan preps, you're going to miss some of the marginal integrity. And you can tell when you miss the integrity when you take an impression. If you do, you take another one till you get it right. And by doing so, it gives me control of the cases. Once I see the cases mounted and the dies trimmed, then I can communicate with the lab directly. And we're a partnership that we work together so that by doing so, we can establish all the things that are accountable for success: occlusion, contours, margins, and all the above. So the principles of dentistry, both fixed and removable, are the same. We may be using different to get there, particularly now that things have modernized, but the principles are the same. And if you compromise the principles, you compromise the end result.
And your principle is, and it's always been, attention to detail. And
Correct.
I can't thank you enough because there are so many cases where we do for other customers where I'm looking at exactly the same things you're looking. I'm looking at the dye trims, I'm looking at the margins,
Yeah.
I'm looking at the articulation, and I'm thinking, scratching my head going, how are we going to make this work? But you take care of all of that for us. You always have, and you've probably done it for the labs that you did business with before you joined us. I'm going to throw a number out there because to me, it's really astounding. Over the past 12 years, we've done over 11,000 cases, and you have a remake rate of 0.25. It's like 27 cases out of 11,000, which is, to me, that's extraordinary. And that goes back to your details.
That's my whole idea. Sometimes it's due to broken dies, which is rare, but in doing it, just like we taught students way back when, there's no substitute for perfection. And that's what the success of dentistry is all, at least to me. I still probably make my temporaries in an old fashioned way where I mix methyl methacrylate acrylic and I carve each and every temporary
Oh, wow.
individually. And I pay close attention to marginal integrity and contacts and contours. And it pays off because when you come back, whether it's a single crown or a three-quarter crown or a full arch splint, your tissues are not grossly hemorrhagic. They're not hypertrophied. They don't interfere with the positive seat of your restoration. The patient is not in distress of healing or anything. And so that extra few minutes of having to raise that way pays a big dividend, at least for me in the end. And it keeps your skills of what you took as freshman dental anatomy, it keeps your skills up because what you're doing is carving a tooth.
Yeah,
And,
from a block of
you know,
resin. That's not.
that's exactly right. It's just like when you were a freshman in dental school, you did it on chalk.
Mhm.
And same thing.
And that technique does pay off. We receive cases back from other customers where it'll say on the LabRx, I had to re-prep because a margin line was showing. And that's because their provisional was too bulky and the tissue receded from the margin during the interim phase. So your technique with contouring the provisional right to the margin and not over bulking it really presents a nice picture of tissue health during the interim phase.
And what you must remember is this: if you create a height contour on either the permanent tooth or the temporary tooth, if you make it too bulky, you're going to drive the tissue gingivally. You're going to cause recession or shrinkage. If you make it ideal, then you're going to allow the tissue to stay at a static level without irritation. And that's where you want the margin to be. That's where it will be. And after a crown's been in the mouth for 50 plus years, you are sometimes going to get some recession. And that's just the aging process. And I've got thousands of crowns and thousands of patients that are 50 and 55-year post-ops. I guess the oldest restorative case I have is a patient of mine who's now in their late 90s
Wow.
was a patient of mine when I was a junior in dental school. And the inlays and onlays are still there. All the lady has done in all these many years is come in for a recall. And to me, there's a lot of changes that have happened in dentistry over my career. I'd say if you had to pick three of the most important changes that I have seen, the first would be the high-speed handpiece, which really came into effect in the 50s and the 60s, which enabled us to be much more productive and atraumatic. The automatic toothbrush and fluoride. There's no question that fluoride has diminished the decay rate in the population. And the automatic toothbrush has greatly enhanced oral hygiene in patients and dental implants I would have to throw into the mix. Now, the problem in dental implants that I think sometimes people overlook is you're not going to have a sensitivity problem because you're dealing with an inert object. But more importantly, you have to pay utmost attention to crown contour, to occlusion, to marginal integrity. And that has a great deal to do with the success or failure of your restoration. When I first started, we didn't know any better. We, on a few cases, would have placed implants and integrated them with a natural tooth in the posterior with tube block attachments. And it wasn't too long thereafter where we saw extrusion of the anterior abutment because of the way the occlusal forces go on it. We don't do that anymore. You don't attach implants to natural teeth because you're dealing with a natural object versus an ankylosed object. And I'd say my oldest, I've got some post-op implant cases that are 30 years old and they're still functioning well. And other things have change that have made the practice easier, more accurate to some degree. The integration of computers and the way we do cone beams and implant placements and things of that sort. But to young doctors who are starting off, still, I think the most important thing they can do and invest in is a great staff because you can buy all the best equipment, fanciest equipment, prettiest equipment you can find. None of it is going to make your life easier or grow your practice without having excellent staff around you. And that is a big asset that these people should always take into. Younger patients don't have much disease. Young doctors, I hope not many of them get entrapped into going into these commercial dental deliveries, although I think it is forthcoming. But there are too many dentists nowadays that I see that treat the codes rather than the patient. And once you do something that doesn't need to be done and is not a conservative treatment plan, you're just asking for trouble and it will come back to bite you. And it does every time.
You put that very succinctly to me in one of our prior conversations where you said, treat the patient, not the pocketbook, and you'll
That's
have a
right.
rewarding career.
That's
And
exactly right.
I can't, I,
And
I
there
can't,
there are other things that I do, for example, that young people may not do that you might call more exotic. For example, if you're going to do a fixed removable denture, let's say, I don't like using bar retained or screw down dentures because the patient can't clean them. And if something breaks, you got to start from scratch almost. And so I think the better way, at least in my hands, of treating these kinds of cases is with multiple implants. Let's say you're working on the mandible, you have 4 or 5 implants in place, and use O-ring or zest anchors. And the patient's going to have an extremely secure attachment. They can take them out, they can clean them, and the expense of doing this is less to the patient for it is good a result in the long term. And
the benefit of hygiene and removing that prosthesis and being able to clean around the fixtures and attachments is phenomenal. And,
that's exactly right.
you know,
I don't use I don't use any composite cements. I still use zinc oxyphosphate cement. In
and you've
my
never had,
hands,
and when was the last time one of your crowns came off?
I can't remember.
Yeah.
If a crown comes off, it's because a patient has had an accident, broken a tooth, or has decay, which has undermined the retention. And that's a perfect example. One of the cases that y'all will get that goes out of here today is an implant done 25 years ago, and it had a PFM crown on it. A lady bit down on an ice cube, broke some of the porcelain. It's just a replacement of the crown. The implant is fine.
You
But
have a great technique for restoring implants. You use the 3i encode system. If you could briefly explain your protocol and the rationale, because I love it. As everything with you, it's extremely high quality and it prevents failures from happening.
well, the rule of dentistry is like the rule of life, and it's called the KISS rule. Keep it simple, stupid. And when you go by that rule, you almost always have a positive result. When we first started doing implants and used gingiva post and or wax copings, the cast and so forth, they weren't quite as accurate as you wanted. There was a lot more technique to it. And as you increase technique, you also increase the potential for error. With the Zest anchors, with the encode abutments, you can either scan them or you can take a direct indirect impression the way I do, mount them, send them to y'all. The abutments are milled, they're perfect. And what I do is put 4 flat walls on every abutment with grooves in them for retention and with a seating index. Once they come back to me with heat process temporaries on them, I place them in the mouth, temporize them. Maybe 50% of the time, I will leave the temporary on for a couple of weeks for the tissue to heal. The other 50%, the margins will be at the crest of the gingiva or even super gingival sometimes in the lower post areas. And I can take the final impression for the final crown at that point. But I think it's a wonderful way of doing it. If you do it correctly, it's almost error proof. It does take a little bit more time over the period of time, but in the long run, it's success. I'm not a big fan, although I do them because these cases are sent to me by the other types of implant companies. God, when we first started, there was 1 or 2 implant companies. Now there must be,
Hmm.
I don't know, 150 or
Yeah.
more. And so you can't work with all. It's impossible to do. I do work on some other implant systems, and we eventually do the same thing in the same way. But I incorporate what y'all call the delineators, which is far better than a flipper partial. It's more comfortable for the patient, and therefore it's more aesthetic. And we use that in the interim. But you can work out your occlusion, your embrasure areas, and everything in the process of doing so. And nowadays, compared to 30, 40 years ago, we don't have to do things like root amps. I don't see much perio in my practice at all. What I see can pretty much be resolved by scaling and root planing and antibiotic intervention. There's a couple of combinations of antibiotics that I'll intervene with the patient to follow up with. And if they do home care, you shrink the pocket depths appreciably. And where we used to have to do root amps and that kind of stuff, you can overcome that nowadays by placing an implant and extracting the bad tooth. There are all kinds of new things that are forthcoming. And one of the neatest things that I read an article about a week or so ago is there's a company in Israel which has developed a stimulating equivalent of the encode impression cap. And in this little encode abutment, there's an electric charge. And as a lot of times the orthopods will give you an electric stimulator to put on a broken bone to increase the osteoblastic activity and healing. This does the same principle. It sends an electric charge down the long axis of the implant body and increases the bone formation quicker. These kinds of things are great for advances. And I still think couple of the best materials we ever had and still do have is gold porcelain and amalgam. I'm old fashioned. I like amalgam in the posteriors in an economic situation for patients more than I like composites. Now, you can say I am truly in the vast minority about that, but I see more redecay under posterior composites than I ever see under amalgams.
Sure.
And I disagree with the point that amalgam causes fractures of teeth. I disagree with that. I think they're no greater, no less than fractures with composites. You certainly don't have the degree of sensitivity or what have you. And if you have a patient who comes in and they can't afford the crown at that point, but has big carious lesion or whatever, you can restore the tooth with amalgam until such time as they can afford to do the crown. Now, you could do the same thing with composite, but I just like using, one day they may take it off the market. And at that point, obviously, you can't use it anymore. But that goes with a lot of the crazy stuff that goes on in the world nowadays.
There is definitely a purpose and a use for amalgam and metal in the mouth. They don't call it the gold standard for nothing. Gold
No,
and
and
the
the other
inlays and
thing
onlays
is
that you've done, the patient that's in her 90s that you treated in dental school, I bet those onlays are as marginally intact today as they were the day you delivered them. And
absolutely, they were all done with modulate gold. The company then was Jalenko, who
yeah,
doesn't exist anymore. I don't know who they were bought by, but it doesn't exist anymore. But those in dentistry, we get pushed and driven by the manufacturers. We are sort of their field testing unit. And if they don't sell enough of a product, they quit making it. And the reason for that is the dentist find using it turns into failures in their hands. So they quit buying it. In medicine, up until now, everything is tested long before you can administer a drug or a technique that you apply onto your patient. And it should be basically the same way in dentistry. But we're the guinea pigs for the manufacturers. And it shouldn't be that way. If you find something that works great for you, that works great, that you have a long prognosis with and everything, stick with it. Why do you need to change?
absolutely. There's a lot of stuff that comes to market that probably shouldn't or was rushed, but I'm of the mindset where you have an established protocol and you follow the steps to the letter, you're not going to have failure at the end. And this, even though they call it the practice of dentistry, is about managing patients, managing lives, treating patients
That's
to the
right.
best of your ability. And once you step outside this box and once you start going into either risky procedures or, iffy products, you're going to incorporate an element of failure into your practice. And that's never,
It's exactly right. And you hit the key word. That's why it's called the practice of medicine and dentistry, because every day you learn something new. Every day you may do the same procedure, but a tiny bit different. And you know why you did it a tiny bit different.
yeah,
The
because
basis,
each patient
the
is
basis,
unique.
that's right. The basis of that is your heretofore practice as to what worked and what didn't work.
Yep. I remember what my dad, patients would come up to him and he was in his 70s when he retired and they would say, "When are you going to retire?" And his answer was always the same. It said, "Well, it's called the practice of dentistry. And when I perfect it, then I'll retire."
Yeah, that's a perfect answer. And we all get that same question. I get it every day. And the people add an addendum to that. They say, please don't retire because
Yep.
we hear war stories about what, happens outside. And it's very true.
You've taken care of probably 3 generations of families now during your practicing lifespan.
Yeah, more than that, some four.
Wow.
And I started in practice, like I said, with my father-in-law, who some of the patients at that point in time were little tiny kids. And now they're in their 90s.
Mhm.
And so that's the whole story. The younger doctors put too much emphasis on dentistry of want, not dentistry of need. And by that, it's so popular to want to whiten teeth and veneer teeth. And that's not really necessary in all cases. Certainly, there are cases where it is necessary, but that's not what should be driving your practice. And I have patients who want their teeth whitened or what have you, and they don't need it, and I won't do it. And some of them go other places, and that's fine. But if you talk to any endodontist for people who continuously do whitening, the problem there is the endodontist will tell you whitening teeth is a boon to their business.
Right.
And there's no question about it. But
Yeah, you're traumatizing the 2 through chemistry repeatedly.
that's exactly what happens. And you got to have all this knowledge to be able to correspond and work with your lab because they're part of your team, just like your staff is. And you can't just send the case to the lab and say, make a crown. And when the crown comes back, it's not contoured right or something's wrong with it, and you blame it on the technician. You can't do that because if you don't know exactly what the technician has to go through to fabricate the crown, you can't criticize the end result. And here in my office, I have my own lab. I glaze all my own crayons after I adjust the porcelain. If I need to do any additions or corrections on a crayon, which is extremely rare, I can bake porcelain here. I never rub a wheel or a surface on porcelain that I've adjusted. It's always glazed. And yeah, it takes about 15 minutes longer. But then again, it saves the patient from having to come back or having a rough surface on a crayon. And
And
those things,
those were the details that I was mentioning before that lead to long-term success because it is more time on your end.
yeah,
It's more work on your end, but you're giving the patient the best possible final results. And I sincerely admire you for that.
there are a lot of people who I think do the same thing as I do, or at least want to think. I've been fortunate in my career to have been associated in the Academy of Fixed Prosthetics with some of the forefathers of Crown and Bridge. And these were in the days when we first started off and porcelain to gold was in its infancy. We still did 3-pin hoods on upper anteriors with long pin facings. And if you were to mention that to a graduating dental student today, they wouldn't know what you were talking about. And you're talking about some real skill levels to be able to drop 3 pins in an upper central and an upper lateral or something and not show any gold when you restored the teeth. Because this was when we were coming out of the years of plastic veneers. We
Right.
didn't have porcelain then. And so we used heat processed acrylic
Right.
in the veneers. Then we got into the early era when you used bright coat on the metal and so forth. And things have just gotten better and better since that time. So I think the metallurgy now, the porcelains now with micrograins and everything, they're really beautiful restorations. Zirconium base with y'all's KDCs, they're as accurate, the margins are as accurate as cast gold is when you do a good preparation with no undercuts, 3-degree parallel walls. They're beautiful restorations as compared to when years ago we had to do porcelain jackets with butt joints. And the way we did porcelain jackets when I was in school is you took a denture tooth and you hollowed it out and then you baked the porcelain to the lingual of the tooth and around the margins. And that's how you made a porcelain jacket.
Hmm.
You would foil the die. And so you're talking about a lot of time and a lot of work. And it looked good sometimes, but the accuracy of the butt joints weren't the greatest. So we've come a long way on that kind of stuff.
Well, definitely. Materials have gotten better. They've gotten more aesthetic. Your background with your high degree of mechanical retentiveness on the preparations, materials have overcome a lot of things that you were taught, particularly like you just talked about with the butt joints. Materials are
Yeah.
stronger. We compress a restoration. We compress an Emax restoration down to 3/10 and hand finish it down to 2/10, and it's going to be plenty strong once it's bonded in the mouth. But with your background, the mechanical retention was all you had, and you still use zinc phosphate cement, and nothing comes off. It's
Well,
brilliant.
at least in my hands, the zinc phosphate cement gives you a ability to seat that restoration perfectly as you expect it to be, right down to the margin. The viscosity of the cement, when you know how to mix it correct, gives you the proper seating. If you're seating a 6, 8, 9 unit splint, let's say, at least in my hands, with a composite cement, you can never get it down evenly. It wouldn't be a passive seat. And the reason for that is because you're going to get setting in one of those units quicker than you're going to get it in the other units. So you're not going to get the prosthesis down. And the failure rate has been incorporated right then and there. Occlusion, you're going to get internal stress, something's going to break, something's going to work loose, you're going to get redecay. And if it happens in a short period of time, then you got to replace the prosthesis for the patient. It's not their fault, it's your fault.
Yeah.
And you don't have to deal with that when you're dealing with zinc phosphate cement because you can control the viscosity of it and you get an excellent seat. It's the same thing if you were doing and other people would probably argue with you tremendously and would argue with me. If you're screwing down a full arch prosthesis, let's say, you're not going to get the same torque on every screw you put into the implant. So you've got built-in discrepancies, whether you realize it or not. And so when you do enough crown and bridge, you understand you can cement these prostheses, but you can do them in sections where you don't have to seat a 12 or 14-inch unit splint all at one time. You don't have to do that. And if you think you did, then you need to redesign the treatment plan of what you were doing, and you'll be much, much better off. And so will the patient with an excellent end result. And the last thing I would say is you need to establish a working relationship with an excellent endodontist, orthodontist, and oral surgeon. And when you do that, you've got the people that you need to work with, and you can't think you're going to do everything yourself and have a complication one day and something breaks or you break off a root and you're extracting a tooth. You can't just pick up the phone and say, "Hey, Joe, the oral surgeon, you got to get me out of trouble here. Take this out." Because you don't have any relationship with them. But if you work with them all the time and you happen to be taking out a tooth on emergency and that happens, they're glad to see them.
The relationships, just like you said, are so important. I know a lot of dentists do try to do everything, and part of me applauds that, but you're always going to have a case that's beyond your skill level, maybe as a general dentist, and having the relationships with somebody who has that extra training and that confidence to go in and retrieve a root tip and bail you out is vital. That's extremely important.
That's exactly correct. Listen, the oral surgeon couldn't do a crown, and I couldn't do as well of the placement of the implant that he does because he does it all day, every day, and I do crowns all day, every day. That's why he gets the success that I anticipate, and I get the success that makes him look good from my end.
And you
And
guys work as a
patient
team.
benefits. That's exactly right. That's
Excellent.
exactly right.
Well, Dr. Weinstein, you have always been so kind and generous to all of us here at Keating Dental Lab. I sincerely appreciate everything you've done for us. I learn something from you every time we speak. I am so fortunate to be able to see and work on your cases at the bench because you've taught me, and you probably don't know this, but indirectly, you've taught me so much about crown and bridge and fixed prosthodontics over the years. I'm forever indebted to you for the education and wisdom you've imparted on me and everything you've taught us today. This is going to be so valuable for the younger generation of dentists listening because you've really you don't practice dentistry anymore. You've truly perfected it, and I thank you for that.
I appreciate your kindness, and I hope any young people who listen will take that advice to heart. Find a mentor somewhere and join up with them. It's worth your time. And just as I mentioned before, partner up with good referring docs and with an excellent lab, and you will have nothing but gains, pluses, and no minuses to speak of. And you'll have a enjoyable career.
That's what it's all about.
Yep.
Well, Dr. Weinstein, thank you so much. I know you have patients to treat this afternoon, and
Yeah,
I
I got a
really
couple left.
I really appreciate your time and Again, all your wisdom is greatly appreciated, not just by me, but everybody here at the laboratory and everybody listening to the Dental Up podcast. Thank you so much.
Okay. Glad to help. Have a
Uh,
good day.
you too, doctor. Thank you.
Bye bye.
Thank you for listening to the Dental Up podcast, your daily source for insights from dentists and leaders in the industry. This episode is sponsored by Keating Dental Lab, here to add value to your dental practice. With high-quality restorations, friendly, reliable service, the best products and prices, come experience the Keating difference. Visit KeatingDentalLab.com for details.